Hello, my name is Samara White. I'm a pharmacy resident here at Buffalo Psychiatric Center. Today we're going to be talking about alcohol use disorder and opioid use disorder. We'll start with alcohol use disorder, also known as AUD.
Alcohol use can be associated with various physical and emotional issues. The negative ramifications associated with alcohol use are related to the amount of alcohol that a person uses, not to the type of alcohol consumed. There are two main types of alcohol abuse: binge drinking and alcoholism. Binge drinking is the consumption of a significant amount of alcohol in a single time span, and is considered to be significantly more than one would normally consume in that time frame. Binge drinking behaviors typically begin in late adolescence or early adulthood, often when individuals are in college or university. Those who continue to binge drink are more likely to become heavy drinkers and to develop issues with alcohol abuse or alcohol use disorders. The formal criteria to objectively measure binge drinking episodes was put forth by the Substance Abuse and Mental Health Services Administration, or SAMHSA, and the National Institute of Alcohol Abuse and Alcoholism, NIAAA. This criteria consists of three main points: the consumption of 4 or more alcoholic drinks on the same occasion within 2 hours by females at least one day during the month. The consumption of 5 or more alcohol drinks on the same day within 2 hours by males at least one day a month. The consumption of alcohol in a single time frame that raises one's blood alcohol concentration to a level of 0.08 at least one day a month, estimated for most females and males as being the number of drinks listed above. Heavy alcohol users are considered to be individuals who binge drink 5 or more times during a month. Drinking like this raises the concentration of alcohol in the blood, as the body's vital organs are unable to clear out that much alcohol in such a short time span. As we have just discussed what binge drinking is, we should examine what alcoholism is. The Centers for Disease Control and Prevention, or CDC, outlines alcoholism as dependency on alcohol. Individuals with alcoholism or alcohol use disorder, AUD, have a strong craving for alcohol. Often, they continue to drink even when doing so causes them physical or social problems. People like this may try to limit or stop drinking, but they may be unable to do so due to the cravings they feel and the drinking habits they have. Someone with alcoholism typically drinks every single day. This is a pattern of behavior that people find difficult or impossible to amend. Someone cannot drink just once and qualify for an alcoholism diagnosis. The behaviors must be repeated in order for the diagnosis to be made. Today, alcohol is the second most abused substance in the world, following nicotine. But what really occurs inside our brain of those suffering from AUD? It is currently understood that chronic alcohol consumption is associated with an increase in inflammatory cytokines in both the peripheral and central nervous system. Alcohol induces an inflammatory response in the brain, which increases the thickness and length of microglia, the immune cells of our nervous system. Thus, they become activated and induce the production of pro-inflammatory cytokines that, unfortunately, result in neurodegeneration. Also observed in patients is excessive release of neurotransmitters, which are the signaling molecules of the brain to help coordinate and communicate. These two molecular mechanisms are only a few things of what happens on the micro level of one's nervous system, where these changes occur in all parts of the brain. However, these abnormal conditions are much more pronounced in regions of the brain involved with reward sensation, in addition to the parts of the brain involved in decision-making. This explains why those affected with AUD tend to struggle with addiction and often relapse. There are many risks associated with both binge drinking and alcoholism. People who binge drink have a higher risk of experiencing alcohol poisoning, sexual dysfunction, and unintentional injuries. Overall, it is known that alcoholism leads to very severe health risks. An article published in the Journal of American Medical Association reported that alcoholism is a progressive disease and can often lead to death. Alcoholism-related deaths can be caused by liver disease, neurological damage, cancer, malnutrition, heart disease, and diabetes. People who binge drink may find it hard to amend the way that they consume alcohol. According to the NIAAA, brief interventions can help, which include several short one-on-one sessions with a qualified counselor. This includes a discussion on how the person drinks and why that drinking pattern seems comfortable to that person. After this, they may develop a step-by-step plan that the person can use in order to change their drinking habits. However, some people with binge drinking issues are required to enroll in a formal rehab program that combines counseling and support group work in order to recover. People with alcoholism endure very serious health risks if they attempt to get sober alone. Long-term alcohol abuse can change chemical signaling within the brain, and without alcohol, people with alcoholism can experience seizures. Medical detox teams can use medications to soothe those worries so people can get sober without feeling ill. That medical detox work must be followed by a formal rehab program in which people will work with counselors, social workers, lifestyle coaches, and peers in order to develop a targeted set of skills. If one suspects that they are frequently binge drinking, it is extremely important to consult with a licensed medical health professional who specializes in addictive behaviors regarding their use of alcohol. A mental health professional can perform a formal assessment of the individual and then make recommendations regarding how the person should proceed. Individuals who develop issues with problematic use of drugs and alcohol require professional assistance and support.
From Psych Hub and Columbia University Department of Psychiatry and presented by HCA Healthcare. You ask, we answer.
So there's a wide range of treatment options and level of care, but the way that we decide what's appropriate is really based on someone's motivation, the severity of their substance use, what sort of supports do they have in their living environment, what sort of maybe co-occurring concerns do they have, is there a risk to their safety or their physical health. The highest level of care for substance use disorders, we look at a residential treatment center. So a residential treatment center might include a detox center where maybe someone has experienced withdrawal symptoms or is vulnerable to experiencing withdrawal symptoms, and they need to be medically supervised to come off alcohol. They may then step down to a residential treatment center where they're actually in a residential environment. That can be anywhere from 14 days to 90 days, where they're receiving really around-the-clock care in a therapeutic environment, targeting the treatment of substance use. Below that, we also have outpatient options. So there's intensive outpatient programs, which is group therapy while you're living at home. There's also just outpatient groups. So there's individual therapy, and there's also addiction psychiatry. Another level of care is sober living, where someone might not be in a residential level of care, but they might reside in a living environment where everybody in the home or the apartment identifies as in recovery or in treatment for substance use disorders. Some of the treatment approaches that we often use are evidence-based treatments, including treatments such as motivational enhancement, CBT for substance use disorders. There's also DBT for substance use disorders. And we often collaborate with addiction psychiatrists. So not only the therapy component, but the psychiatry component. So from a medication perspective, there that help to treat alcohol use disorder. Depending on someone's goals or needs, that can be more of an abstinence-based treatment. So there's a medication called Antabuse, or it can be something that treats cravings. So there's a medication called naltrexone. Anybody that's seeking help or treatment for a substance use concern, I think can find an effective treatment.
We have three main medications for treating AUD. Our first medication is naltrexone, also known as Vivitrol. This medication helps decrease cravings by blocking the effects of alcohol. So if someone is not able to feel the euphoria of getting drunk, they're less likely to crave alcohol in the first place. This medication comes in daily tablets or monthly injections, and the cool thing about naltrexone is that it treats both AUD and OUD. Our next medication is disulfiram, also known as Antabuse. This medication helps people abstain from alcohol completely because it creates a very uncomfortable reaction when mixed with alcohol, even if it's just a small amount. Because of this, people should avoid drinking alcohol for at least 2 weeks before starting this medication. The last medication is called acamprosate, also known as Camprol. There's not too much you need to know about this medication, but it works by resetting the neurotransmitters or brain chemicals that are affected by alcohol use. Next, we'll let the experts tell us about opioid use disorder, also known as OUD.
What are opioids? Opioids are chemicals that interact with opioid receptors in the body and brain and are intended to reduce the perception of pain. Doctors may prescribe opioids for short periods of time to treat pain. Opioids are powerful pain relievers, but can also be very dangerous when not taken as prescribed. Opioid use disorder, or opioid addiction, is a treatable medical condition that can lead to serious consequences. Some of the signs of opioid use disorder include continuing to take opioids even though you want to stop, needing to take more and more opioids to feel the same effect, finding that taking opioids is causing problems with work, family, and friends, feeling sick when you don't take opioids. Opioid use disorder is especially dangerous because the brain adapts to opioid use quickly, and this can rapidly lead to physical dependence. This dependence leads to a person experiencing severe withdrawal symptoms if they stop using opioids and creates a strong motivation to continue using. Unfortunately, over 2.7 million Americans have experienced opioid use disorder. Opioid overdose has become a leading cause of death for Americans aged 18 to 45. For every fatal overdose, there are about 10 non-fatal overdoses and 20 opioid-related hospitalizations. Some opioids, such as fentanyl, are especially dangerous. Fentanyl is 50 times more potent than heroin, 100 times more potent than morphine. If you have a friend or family member struggling with opioid use disorder, help is available and recovery is possible. Treatment can include medication and therapy. Buprenorphine, methadone, and naltrexone are 3 effective FDA-approved medications for the treatment of opioid use disorder. You can help people with opioid use disorder by learning about and carrying naloxone, which is an over-the-counter medication that keeps someone who is experiencing opioid overdose alive until an ambulance arrives. For more information, please visit www.psychiatry.org.
More than 3,000 years ago, a flower began to appear in remedies in ancient Egyptian medical texts. Across the Mediterranean, the ancient Minoans likely found ways to use the same plant for its high. Both ancient civilizations were onto something. Opium, an extract of the poppy in question, can both induce pleasure and reduce pain. Though opium has remained in use ever since, it wasn't until the 19th century that one of its chemical compounds, morphine, was identified and isolated for medical use. Morphine, codeine, and other substances made directly from the poppy are called opiates. In the 20th century, drug companies created a slew of synthetic substances similar to these opiates, including heroin, hydrocodone, oxycodone, and fentanyl. Whether synthetic or derived from opium, These compounds are collectively known as opioids. Synthetic or natural, legal or illicit, opioid drugs are very effective painkillers, but they are also highly addictive. In the 1980s and 90s, pharmaceutical companies began to market opioid painkillers aggressively, actively downplaying their addictive potential to both the medical community and the public. The number of opioid painkillers prescriptions skyrocketed, and so did cases of opioid addiction, beginning a crisis that continues today. To understand why opioids are so addictive, it helps to trace how these drugs affect the human body, from the first dose through repeated use to what happens when long-term use stops. Each of these drugs has slightly different chemistry, but all act on the body's opioid system by binding to opioid receptors in the brain. The body's endorphins temper pain signals by binding to these receptors, and opioid drugs bind much more strongly for longer. So opioid drugs can manage much more severe pain than endorphins can. Opioid receptors also influence everything from mood to normal bodily functions. With these functions too, opioids' binding strength and durability mean their effects are more pronounced and widespread than those of the body's natural signaling molecules. When a drug binds to opioid receptors, it triggers the release of dopamine, which is linked to feelings of pleasure and may be responsible for the sense of euphoria that characterizes an opioid high. At the same time, opioids suppress the release of noradrenaline, which influences wakefulness, breathing, digestion, and blood pressure. A therapeutic dose decreases noradrenaline enough to cause side effects like constipation. At higher doses, opioids can decrease heart and breathing rates to dangerous levels, causing loss of consciousness and even death. Over time, the body starts to develop a tolerance for opioids. It may decrease its number of opioid receptors, or the receptors may become less responsive. To experience the same release of dopamine and resulting mood effects as before, people have to take larger and larger doses. A cycle that leads to physical dependence and addiction. As people take more opioids to compensate for tolerance, noradrenaline levels become lower and lower, to a point that could impact basic bodily functions. The body compensates by increasing its number of noradrenaline receptors so it can detect much smaller amounts of noradrenaline. This increased sensitivity to noradrenaline allows the body to continue functioning normally. In fact, it becomes dependent on opioids to maintain the new balance. When someone who is physically dependent on opioids stops taking them abruptly, that balance is disrupted. Noradrenaline levels can increase within a day of ceasing opioid use, but the body takes much longer to get rid of all the extra noradrenaline receptors it made. That means there's a period of time when the body is too sensitive to noradrenaline. This oversensitivity causes withdrawal symptoms, including muscle aches, stomach pains, fever, and vomiting. Though temporary, opioid withdrawal can be incredibly debilitating. In serious cases, someone in withdrawal can be violently ill for days or even weeks. People who are addicted to opioids aren't necessarily using the drugs to get high anymore, but rather to avoid being sick. Many risk losing wages or even jobs while in withdrawal, or may not have anyone to take care of them during withdrawal. If someone goes back to using opioids later, they can be at particularly high risk for overdose, because what would have been a standard dose while their tolerance was high can now be lethal. Since 1980, accidental deaths from opioid overdose have grown exponentially in the United States, and opioid addictions have also exploded around the world. While opioid painkiller prescriptions are becoming more closely regulated, cases of overdose and addiction are still increasing, especially among younger people. Many of the early cases of addiction were middle-aged people who became addicted to painkillers they had been prescribed, or received from friends and family members with prescriptions. Today, young people are often introduced to prescription opioid drugs in those ways, but move on to heroin or illicit synthetic opioids that are cheaper and easier to come by. Beyond tighter regulation of opioid painkillers, What can we do to reverse the growing rates of addiction and overdose? A drug called naloxone is currently our best defense against overdose. Naloxone binds to opioid receptors but doesn't activate them. It blocks other opioids from binding to the receptors and even knocks them off the receptors to reverse an overdose. Opioid addiction is rarely a standalone illness. Frequently, people with opioid dependence are also struggling with a mental health condition. There are both inpatient and outpatient programs that combine medication, health services, and psychotherapy. But many of these programs are very expensive, and the more affordable options can have long waiting lists. They also often require complete detoxification from opioids before beginning treatment. Both the withdrawal period and the common months-long stay in a facility can be impossible for people who risk losing jobs and housing in that time frame. Opioid maintenance programs aim to address some of these obstacles and eliminate opioid abuse using a combination of medication and behavior therapy. These programs avoid withdrawal symptoms with drugs that bind to opioid receptors but don't have the psychoactive effects of painkillers, heroin, and other commonly abused opioids. Methadone and buprenorphine are the primary opioid maintenance drugs available today, but doctors need a special waiver to prescribe them, even though no specific training or certification is required to prescribe opioid painkillers. Buprenorphine can be so scarce that there's even a growing black market for it. There's still a long way to go with combating opioid addiction, but there are great resources for making sense of the treatment options. If you or someone you know is struggling with opioid use in the United States, the Department of Health and Human Services operates a helpline, 800-662-4357, and a database of more than 14,000 substance abuse facilities in the U.S. www.hhs.gov/opioids.
This is Susan. Susan loves to bike. While out for a ride, she falls and breaks her arm. Special cells called neurons send a signal through the spinal cord to the brain, which interprets the signal as pain. Susan understands the pain means she needs to go to the hospital, and her body is equipped for survival, helping her not to panic so she can seek help. Many of her neurons are covered in proteins called opioid receptors. These receptors act like a brake to slow down the neuron's ability to send pain signals. When injured, her body releases natural painkillers called endorphins. Like a key in a lock, endorphins activate opioid receptors, slowing down the pain signal and preventing a panic. Susan gets treated for the broken bone, but 3 months later, her arm still hurts. And now that pain is making her feel depressed and anxious. So her doctor prescribes an opioid painkiller. There are many different opioids, but they all share a chemical similarity to our own endorphins. This allows them to bind to the same opioid receptors and stop pain signals. But that's not all they do. Deep inside Susan's brain is a region called the ventral tegmental area, or VTA for short. The VTA is full of neurons that produce a chemical called dopamine. When something good happens, dopamine is released, giving Susan a feeling of pleasure. This helps teach her brain to keep seeking out good things. To keep dopamine neurons in check, inhibitory neurons keep the brakes on until something good comes along. Just like the pain neuron, these neurons are covered in opioid receptors. When Susan takes the painkiller prescribed by her doctor, the opioid receptors turn off the inhibitory neurons and release the brake on the dopamine neurons. The rush of dopamine temporarily eliminates Susan's depression and anxiety, and she feels relief, calmness, and even euphoria. As Susan continues to take the painkillers, her brain responds by trying to regain its balance. Her inhibitory neurons work extra hard, even when the opioid receptors are activated, and it becomes harder and harder for her dopamine neurons to release dopamine. Susan finds that she needs to increase her dose of painkillers in order to feel comfortable. This is called tolerance. Eventually, Susan's pills run out. Inhibitory neurons that had been working overtime are let loose, clamping down on those dopamine neurons and shutting them off almost completely. Now, not only is Susan in pain, but the depression and anxiety come back. On top of that, Susan feels ravaged by an inescapable physical sickness far worse than any flu. Susan's body is going through withdrawal. Most people who take opioids for a long time tend to experience some withdrawal, but they can still stop taking the pills and return to normal. But for people like Susan, it's not so easy. Her genetics and the environment she grew up in put her at a higher risk for addiction. Her withdrawal symptoms aren't just unpleasant, they're unbearable. Susan thinks the only way to feel normal is to find more opioids. And this is how the cycle of opioid addiction emerges, driven by a brain trying to regain its balance. But there is hope for Susan. Though the road to recovery can be challenging and there may be setbacks, treatment can retrain Susan's brain. With the help of medication and therapy, Susan finds pleasure in her life once again.
I came into outpatient treatment angry and defensive. I left with hope.
My 12-step program is so important to me. I don't know what I would do without my sponsor.
At first, I couldn't see what my treatment program was trying to do. But now that I'm clean, I use what they taught me every day.
I tried to kick heroin for years. Turns out there was actually some medicine that helped me. And now I have my life back.
Opioid use disorder impacts millions of people. It is a collection of symptoms that take away people's ability to be in control of their opioid use. Decisions about using opioids, when and how much, become harder and harder to manage. People start to need more of the medication to get the same effect, and sometimes are blind to the damage that opioids are causing in their lives. And that damage can be huge. Even though using opioids can ruin your health, relationships, and daily life, it is really tough to quit on your own and can even be dangerous. But there is good news. There are treatments that help people recover and get back to living the way they want to. Treatment looks different depending on how severe a person's opioid use disorder is. For example, someone might have medical problems that make withdrawal dangerous, or someone else might have used so much that he or she needs to be in the hospital for detox, rehab, or intensive counseling. For some people, medication-assisted treatment, or MAT, is a life-saving intervention that allows safe and effective cutting back of opioid use. In MAT, a physician prescribes a different medication with much lower risk that helps people stop using opioids. Other people get help using different programs. Some are short-term, others take longer. Some involve clinical professionals, such as therapists or addiction specialists. These providers might use cognitive behavioral techniques like motivational enhancement to connect people with parts of their lives that help them stay in treatment. Another technique that is sometimes used in intensive treatment programs is called contingency management, which rewards people for certain behaviors in their recovery. Additional treatment programs are peer or community-based, such as 12-step programs like Narcotics Anonymous for opioid users. These programs are free, open to anyone with a desire to stop using, and operate on anonymity. Members meet with others who understand their struggles. The research on 12-step interventions shows that the best results happen when new members attend meetings and work the steps with sponsors who are fellow members in recovery. The choice about what kind of treatment to engage in is influenced by many factors. Most importantly, what you need and what will work for you at this time in your life. Regardless of where you turn, know that many people have cut down or stopped using opioids and have achieved lasting recovery. The first step is often the hardest, but it's the most important, and there are people everywhere that understand these challenges and how to get past them. Make that first step. There is hope, and there is so much more.
Opioid use disorder is a chronic but treatable condition. Several medications can help support recovery and improve health by reducing cravings, easing withdrawal symptoms, and even reversing an opioid overdose. These medicines are safe, effective, and save lives. Medications for opioid use disorder can be used alone or as part of a larger treatment plan. Each medication works in a slightly different way, but they all fit into very small cellular structures in the brain called receptors, sort of like a lock and key. Here's a closer look at medications for opioid use disorder and how they work. Naloxone is a medication that can save a life in the event of an opioid overdose. When given right away, naloxone works in minutes to reverse an opioid overdose by kicking the opioids off opioid receptors in the brain. This stops opioids from continuing to cause dangerous effects, like slowing or stopping breathing. There are two forms of naloxone, injectable and nasal sprays. Anyone can carry naloxone. In many areas, these emergency medications are available at pharmacies without a prescription. Lofexidine is a tablet that can be used as needed to ease withdrawal symptoms as someone stops taking opioids and the drugs begin to clear completely from their body. This is a process some people call detoxing. Lofexidine attaches to and activates certain receptors called adrenergic receptors in the brain. This relaxes parts of the nervous system to alleviate the nausea, cramping, and flu-like symptoms associated with opioid withdrawal. Buprenorphine is an opioid medication that attaches to opioid receptors in the brain but activates them only partially. In this way, buprenorphine helps reduce opioid cravings and ease withdrawal symptoms in people with opioid use disorder without producing the same high as other opioids. Buprenorphine is a monthly injection or daily tablet that dissolves under the tongue. Buprenorphine may be combined with the medication naloxone in a single daily tablet that dissolves under the tongue or a small film that sticks to the inside of the cheek and dissolves. Another medication, methadone, has been used successfully for more than 40 years to treat opioid use disorder. It comes in a liquid or a tablet and is taken daily at a treatment center. Methadone is an opioid medication with slower and more stable effects than other opioids. This medication doesn't produce a high in people with opioid use disorder. This allows methadone to ease withdrawal symptoms, curb cravings, and support recovery. Naltrexone is a monthly injection used to treat both opioid use disorder and alcohol use disorder. Naltrexone blocks the activity of opioid receptors in the brain, preventing the high associated with these drugs and reducing cravings. Naltrexone does not control withdrawal symptoms and is used after someone stops taking opioids or alcohol and the drugs clear completely from their body. If you or a loved one has an opioid use disorder, talk with a healthcare provider to learn more about how medications can help.
Thank you, everyone, and have a great day.